Hi everyone, I'm Dr. Jiahong Gao from Taipei, Taiwan, and welcome to our APASL Hepatology COVID-19 webinar, the episode 2 and also the section 2.
Thank you, Professor Gao, and then it's my great honor to chair this session with you. And then, dear friends, my colleagues, although the COVID-19 epidemic blocked us to discuss face-to-face, but the internet bring us together for this webinar. And then a moment ago, Professor Omata gave us a wonderful presentation about the evidence used in the treatment of diseases COVID-19. Today, it's our honor to invite Professor Gregory Cheng to give us a presentation. Briefly, I give an introduction for Professor and Dr. Cheng. He is the consultant hematologist at the University Hospital, Macau, and then the director of Humanity and Health Clinical Trial Center, Humanity and Health Medical Group, Hong Kong. He earned his medical degree and then PhD degree from University of Toronto in 1978 and 1989, respectively. His clinical practice and research focus on immune thrombocytopenia, deep vein thrombosis, and others. Also, during the last several years, Professor Cheng, his hematology department has been involved in phase 1 to phase 3 clinical trials of several groundbreaking and new therapeutic approaches. Like this clinical trial include, but not limited to the pulsed dexamethasone and atropine in IPD and others. Also, Professor Cheng has published a lot of papers in New England Journal of Medicine, JAMA Lancet as well. And then today, he will give a talk about the coagulopathy in COVID-19. Dr. Cheng, please.
Thank you, Chairman, for the very kind introduction.
Very good.
Today, I'm going to talk about coagulopathy in COVID-19. COVID-19, in many aspects, is very much like my wife. Initially, I think I understand her and can control her. But after a while, I realized I cannot, and I have to learn to live with her. Coagulopathy is an area where we have little understanding in COVID-19. And just like dealing with my wife, my job today will not be an easy one. What are the common coagulation abnormalities in COVID-19? As you can see, okay, in these two publications involving over 1,000 COVID subjects, platelet count in most cases are normal, and in only less than about 10% or around 10% of the subjects, we have a platelet count below 100 or 150. On the other hand, D-dimers are significantly elevated in a significant proportion of subjects, particularly those with severe diseases. If you compare survivors with non-survivors, you can see that thrombocytopenia is more common among the non-survivors, and elevation of D-dimers, again, observed in over 80% of the non-survivors, compared with only 24% in the survivors. So the issue here is the coagulation abnormalities that we observe in COVID-19. Does it represent DIC, or it only represents a hypercoagulable state? For most patients with COVID-19, particularly those with mild or moderate disease, the platelet count was usually normal and sometimes even increased. Prothrombin time and activated partial thrombin time were near normal in most of these cases. Fibrinogen markedly increased as opposed to in DIC, but D-dimer was markedly elevated. C-reactive protein was also increased. Factor VIII von Willebrand factor also increased. Therefore, for most patients, the coagulation abnormalities more suggestive of a hypercoagulable state rather than DIC. However, in those patients that have end-stage diseases, non-survivors, that with multi-organ failure, over 70% of them fulfill the criteria of DIC, as opposed to only 0.6% among the survivors. Therefore, I would say in COVID-19, only those that have severe or end-stage disease have full-blown DIC. For most cases, it represents a hypercoagulable state. The next question will be, will this hypercoagulable state translate to an increased incidence of thrombosis? In this study, 20 out of 81 patients, nearly 25% of COVID-19 patients admitted to the ICU have ultrasound documented thrombosis in the lower limbs. And the authors show that a significant elevation of D-dimer is a good marker for identifying those patients at high risk. If you use 1.5 microgram per ml as the cutoff point for D-dimer, the sensitivity was 85% with a specificity of nearly 90% and a negative predictive value of nearly 95%. In another study, again, they observed around 31% incidence of venous thrombosis in ICU patients. And they show that prophylaxis with low molecular weight heparin is helpful and suggests that all patients with COVID-19 admitted to the ICU should receive either prophylactic or even therapeutic dose. The next issue will be, does treatment with low molecular weight heparin useful in preventing thrombosis in COVID-19 patients? In this study, among the 449 patients with severe COVID-19, 99 of them received low molecular weight heparin for 7 days or longer. And they show that the 28-day mortality was significantly reduced only in those subjects have a high sepsis-induced coagulation score or have a high D-dimer level. Therefore, suggesting that for those patients with a very abnormal coagulation profile, they are the ones that benefited most from anticoagulation therapy. On the other hand, in the study in France, 26 consecutive ICU patients with, again, ultrasound Doppler documented VTE, all of them were on low molecular weight heparin. 30% of them on prophylactic dose and the remaining on therapeutic anticoagulation. But however, despite this, the overall incidence of VTE was 69%. 100% of the patients on prophylactic dose developed VTE. Even for those on therapeutic dose, more than half of them developed VTE and 1/3 of them had pulmonary embolism, suggesting that for patients with severe COVID-19, for many patients, even therapeutic dose of low molecular weight heparin may not be sufficient to prevent VTE. So what should we do? The American College of Chest Physicians, they recommended that in the absence of contraindications, anticoagulation prophylaxis should be given to all critically ill patients admitted to the ICU, and suggested that for all hospitalized patients, they should also receive anticoagulation prophylaxis. What is the choice of reagent for thromboprophylaxis? They recommend low molecular weight heparin or fondaparinux over unfractionated heparin, or oral direct anticoagulant. They recommend that the prophylaxis should be given only for the inpatient hospitalized period. They do not suggest extending the prophylaxis to discharge, to after hospital discharge. For all those patients who have a documented DVT or pulmonary embolism, they recommend full anticoagulation therapy for at least 3 months or more. And then, as mentioned before, some patients, they may develop VTE despite full dose or therapeutic dose of low molecular heparin. And they suggested that in those cases, you may attempt to increase the dose by 25 to 30%. What are the possible mechanisms for the increased risk of thrombosis in COVID-19? One, it may be due to viral-initiated systemic inflammatory response, resulting in subsequent activation of the coagulation cascade and generation of the thrombi, a process called immunothrombosis. It has been observed that decreased level of many anticoagulation proteins, such as antithrombin, C1 esterase inhibitors, protein C, occurred in patients with COVID-19. Also, there was increased plasminogen activated inhibitors activity with accompanying decreased fibrinolysis during COVID-19 infection. The cytokines, like IL-6 levels, again are commonly elevated in COVID-19 patients, and IL-6 has been shown to cause activation of the coagulation cascade. A second mechanism is infection-associated vascular injury. The receptors for SARS coronavirus, the angiotensin-converting enzymes, are present on endothelial cells. And postmortem studies has demonstrated the presence of the SARS coronavirus particles in the endothelial cells of COVID-19 patients. Therefore, it is highly possible that direct virus-induced vascular injury occurred and may lead to activation of thrombosis in COVID-19 patients. One may ask, is there any relationship between hypercoagulable state, which is a hematology phenomenon, and underlying liver diseases, a hepatology specialty? If you look at the alphabet order, you can see that the letters N and O are between the letter M and the letter P. Therefore, if hematologists and hepatologists never say no to each other, then you can see that there will be no boundary between hematology and hepatology. Therefore, it is not surprising that hepatology disease may contribute to the hypercoagulable state in COVID-19. It has been shown that non-alcoholic fatty liver disease was associated with a high risk of progression to severe COVID-19. Also, obesity and NAFLD significantly increased the risk of venous and arterial thrombosis. NAFLD by itself were characterized by a hypercoagulable state with elevated plasma levels of neuroendocrine factor, enhanced platelet activation, and increased levels of circulating plasminogen activated inhibitor. These abnormalities are very similar to the one that has been observed in COVID-19 patients. Therefore, one may ask, does COVID-19 contribute to the high incidence of thrombosis? Does NAFLD contribute to the high incidence of thrombosis in COVID-19 subjects? We therefore, retrospectively look at the previous published data of the 21 subjects with DVT, and we find that 16 out of these 21 subjects, or 76% of them, had NAFLD, as compared with less than 40% incidence in the general COVID-19 cohort. We have also observed that the D-dimers levels were significantly higher in NAFLD subjects as compared with non-NAFLD subjects. These observations suggested that the hypercoagulable state of NAFLD may contribute to the high incidence of thrombosis, okay, in COVID-19 patients with underlying NAFLD. In summary, COVID-19 is a hypercoagulable state, and NAFLD may contribute to the hypercoagulability of thrombosis in patients with COVID-19. And I think at the end of this presentation, you would also agree that Dr. Cheng obviously is a very incompetent doctor, and he should be on the run. Thank you very much.
Thank you very much, Professor Cheng. Thank you for your wonderful presentation about the coagulopathy in COVID-19. Your presentation is very impressive. Yes, hello, Professor Xia Fenggao. And right now, we co-chair the questions and answers right. I have a question to Professor Cheng. And then in Beijing, and in my clinical department, one patient with COVID-19, he died. He is with the obesity, and then the nephew with the pulmonary embolism. I'm wondering how to predicate the incidence of pulmonary embolism or in clinic. What kind of parameters should we test, like the platelets count and then D-dimers as well?
Okay, as you all know, pulmonary embolism is very difficult to diagnose clinically. But I think from all the data, I think patients, particularly COVID-19 patients, we should consider a risk factor. Okay, NAFLD is a risk factor, obesity, and all that are risk factors for VTE. And for those patients with high risk factor, we should, check the D-dimer regularly. And if they already admitted with a high D-dimer level, I think these patients should be put on high dose of prophylactic anticoagulant anyway. And if despite being put on therapeutic dose of low molecular heparin, their D-dimer continued to increase. And if their respiratory function or SaO2 deteriorate, I think those patients, then we may need to do CT scan or whatever to document whether they indeed have PD. If they have pulmonary embolism, despite full dose of anticoagulation, as suggested, we either increase the dose of the anticoagulant, or if their situation is really bad, I may consider giving them thrombolytic therapy in those cases.
Okay, thank you. And any other questions from the audience in our webinar, please? Oh, yes. A question from to Professor Cheng. Yeah. Please. Oh, yes, yes. Yeah. Yeah. What mechanisms exist in NAFLD patients for Professor Cheng?
Oh, you mean the mechanism for the increased thrombosis or hypercoagulability? I think NAFLD by itself, the patients have high level of plasminogen activated inhibitor. Therefore, they have decreased fibrinolysis, making them more prone to thrombosis.
Oh, yeah. 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 Hi, George. Professor Law, what's your comments?
Well, thanks, Professor Wang. And well, we have published our fatty liver disease in relationship with the COVID, which shows that those patients with metabolic associated liver disease or NAFLD has a higher risk of disease progressions and also a prolonged viral shedding. And Professor Cheng, as he has mentioned, we are also observing there is increased risk of venous thrombosis, and the mechanisms involved might be one of your expertise, interleukin-6, which in fact, I want to throw the question back to you because Fusen, you are the first one to publish the autopsy report in Lancet. Very elegant paper, congratulations. And you have the postmortem. And did you have a chance to look at the venous thrombosis in unfortunate diseased patients, and whether there is any, you specifically look for a venous thrombosis and also any fatty liver disease in your patients? Fusen?
Oh, yes, thank you, Professor Lau. Many thanks for your excellent comments and answer questions. And yes, I agree with you. When I worked in Wuhan, in Hosenshan Hospital for 2 months, and then my colleague is Professor Bian. He conducted the autopsy examination for the died patients. He also find the post-mortem study or the examination after for the died patients. His data demonstrated the presence of the viral particles in the epithelial cells. At the same time, he also find there are pulmonary embolism or thrombosis that exist in the lung of the patients in the died patients. Yes. Any other any questions from our audience?
Well, in the current guidelines, I would like to ask our colleagues in Asia Pacific, especially China, whether anticoagulation therapies, as suggested by Professor Cheng, is implemented into the protocol of treating those patients with severe COVID to prevent venous thrombosis.
And also, I find some questions for Professor Cheng. Yeah, the question is, there is any evidence about the thrombosis in the spleen chronic vein in COVID-19 patients? With any evidence about the thrombosis within spleen chronic vein in COVID-19 patients, to Professor Cheng.
There is no published cases. I think one need to look closely at all the autopsy findings to see how prevalent or how extensive are thrombosis in the splenic vein.
Another question is how much mortality reduced by heparin treatment?
If you, in that particular study, for patients with sepsis, induced coagulation score of 4 or more, you can reduce mortality from 64% to 40%. However, for those patients that have a score less than that, there was no significant reduction.
Okay, thank you very much, Professor Gregory.
So I think I have to thank my co-chair, Professor Fusen Wang, for chairing the sessions with me, and all the senior colleagues of the APASL and all the audience online. Thank you very much. So, and see you.
Thank you very much.
Bye-bye.